but he's going to give those points now. Thank you, Paul, for your time.
So I've never been called an established consultant before. That can only mean one thing, that I'm at the wrong end of the age spectrum. So I thought I'd christen this Thoughts from a Dinosaur. 5 things I want to get over for you. And it really runs, I think, from some of the lessons I'm still learning, we're all still learning as an undergraduate dean, is always put the patient first. And as you go through that now in your postgraduate and onto your consultant grade, think about that. I'll talk a little bit about the job plan, wealth creation, and then finally, what the future looks like. So there's an evidence base for this, and a few things I've learnt over the years, which I'm still actually trying to instill in practices, is avoid silos. You come into your life, you're a new consultant, the first thing you want is that name across the door, you know, Dr. Stewart, patient seeing. That is exactly the wrong thing to do in terms of siloing practice. So think of where you can be running generic, think of where you can be learning from colleagues. We're all still learning. John Wass and I still learn every day from patients. And as you're relatively junior now, in kind of real terms in going into consultant roles, what environment are you going to be putting yourselves in so you can still keep learning? And these are just some of the tips where there's an evidence base actually for exactly that process. Training the trainees is a great way of keeping in touch. And I would urge you all to continue to do that. So you know all that, but try and make sure you live and believe it. As you've heard, you're going into this at a stage where you are actually a commodity, a real commodity in terms of what the future consultant workforce looks like. And you have the unique opportunity at the time of your interview to set in place what your job plan looks like. Once you've signed on the dotted line, it becomes very different getting that balance between, you know, the drive towards service delivery versus you having time to live and breathe the kind of things you might want to do. You're going to hear more about research. Research for me isn't about all of you becoming clinical academics, far from it. But there's an evidence base now that institutions that are involved in research, patients that are engaged in research have better outcomes. And once you can argue that at the level of the trust board, this stuff becomes just as important as service delivery. And you are the future disciples of that. So make sure you've got time on your job plans. There's far more than enough money in the system, actually, for you to be engaged in research and do that. And ditto, doctor. Doctor is docere, to teach. And, you know, be passionate about your legacy in terms of making sure that you're fulfilling the pipeline. So as I say, you've really a great opportunity moving from you are now to this highly sought-after commodity, a consultant, to make sure you get that nailed. Now, we're going into an unsustainable system. You know that. We're bankrupt. And the idea that we can give something back and in terms of wealth creation is something that is now mainstream activity, particularly with this present government, and that's going to continue. And on here you see what is badged the UK life health science industry, which effectively, it's not just the AstraZenecas and GSKs, there are 300 pharmaceutical companies in this country. And with those, the medical technologists, the widgets, the new surgical instruments, the new kit. And this amounts to an enormous industry. In fact, it's 8% of the UK workforce. And this was the change, I think, that came through, directly led by Cameron and George Freeman and others, is we are now part of that life health science industry. Whether you're university, NHS, we're all in this together. And the idea that engaging in partnerships, innovative partnership, providing you can still, your strong professional values, make sure you're putting the patient first, this is something we should be doing. So those high and mighty in you think, oh, I'd never work with industries, working with industry, you know, that's a very bad thing to do. That's the wrong attitude. We have to be embellishing industry, we have to be working innovatively in order to see what we're doing in the NHS as growing wealth rather than simply cap in hand and what can we have. Finally, how many of you read this? The 5-year forward view? Hands up. This is the future. So go away and read it. And the future's actually quite scary, but as I look to you, I'm totally reassured that we will deliver the future because you, unlike me, being a relative dinosaur, are the future pioneers of this. But this is what's happening. It's happening in many, many other disciplines, and I sense sometimes that endocrinology might get left behind. There's a huge push now to push care upstream towards home care, delivery models to be integrated across primary, secondary care, social divide. And you think of some of perhaps the management of diabetic patients and maybe thyroid disease, where we could actually do that far more effectively. Healthcare data and outcomes will be used to transform diagnosis. Outcomes will drive payment, not simply you just turning up to a clinic. It's what are you doing, patient-centric way to improve patient output that will drive payment. Technology and, of course, electronic records and the whole data transformation that's coming that will inform healthcare. And the reason why I'm so excited by this is you all live and breathe your lives on these. But how many of you really live and breathe your clinical practice through these? And I'm afraid this is the future. This is what's coming for all the right reasons. And it's kind of integrated, articulated through some of the points here. Patients will become more like consumers. Individuals will be better informed about their health. They will have their data, on a stick, ready to access. Genomic, imaging, biochemical phenotype. It'll be all there. And our job will be more about how we integrate that and come up with a management plan based on what's already there. Ownership of records, and of course all is this going to be driven by a data explosion. So this, to me, if you like, was kind of an example where, in many ways, we've kind of been doing this, but we haven't articulated it very well. This, if you like, was informatics for me in the 1990s, where, many of us were setting up databases. Of course we were. We wanted the best for our patients. We wanted to know what outcome-driven healthcare was like. And this, of course, has helped not only to improve clinical practice, and I just show some of the outcomes here, an evidence base for treatment, but has also provided a very potent research tool going forward. But this is what the future looks like. This is the top floor of our medical school, 42,000 square feet now of data informatics, which largely because the geography of where we are in Leeds, with HES data, with the Health and Social Care Innovation Centre next door, these things here are safe havens where all of that data can come together, so we're not going to have another care.com crisis in terms of integrating all of that to be driving patient outcome in the future. And this is the kind of way it's going, the Leeds Care Record, which really does transcend social care, hospital data, right through into primary care for the management of a patient pathway. That's what's important here. What's the best way of delivering care in that patient pathway? And the background of this has largely to date been cancer-driven, but is now being rolled out across a whole series of other areas, and I'm at the forefront of arguing this for endocrinology. And it just kind of shows the power you can do on this in terms of, because bringing into this electronic patient record is, if you like, real-time data from the Office of National Statistics, the Health and Social Care Innovation Centre. What you have here are live mortality rates for these conditions from midnight the day before. So this is real contemporary data where you can start looking at what the total number of cases you've had, in this case through the Leeds Teaching Hospital, and what current mortality is in your own population. So this is very much the future. I would just look at all of you, because in many ways you are the future, and you grab the opportunities that are there, because I think they are real. I think they're tangible. I think if applied properly, they can revolutionize the future of endocrine practice. But it's going to need a very different way of thinking than the somewhat siloed physician-led way of managing patients that I sense we have at the moment. And that's my final plea. Thank you.